Welcome back to the deep dive. Today, we're tackling something I think every eye doctor has encountered. That moment in clinic, you're looking at macular atrophy, you've got the scans, the history, but something just feels a bit off.
Yeah. It's like trying to tell those two very similar drusen apart in a dimly lit room. Sometimes, as they say, seeing isn't quite believing everything you see.
Exactly. It's those subtle differences, those nuances that can be so critical for diagnosis,
Yeah.
especially with these complex macular conditions.
And the stakes are just getting higher, aren't they? With new treatments emerging, getting it right is absolutely paramount.
Which is why this Australian audit we're discussing today is so important. The title is Retrospective Audit Reviewing Accuracy of Clinical Diagnosis of Geographic Atrophy in a Single-Center Private Tertiary Retinal Practice in Australia. Quite a mouthful.
It is, but the core question is simple. How often are we potentially getting the diagnosis of GA wrong in real-world setting? Our goal today is to unpack this research, pull out the key findings, and figure out the practical takeaways for you listening.
We want to help sharpen everyone's diagnostic vision when it comes to geographic atrophy, or GA.
Because it's such a timely issue, the similarities, the phenotypical overlap between GA, which is late-stage AMD, age-related macular degeneration, and certain inherited retinal diseases, or IRDs, it's striking.
And with new treatments approved for GA and gene therapies being developed for IRDs, well, getting that initial diagnosis correct is more crucial than ever. It really dictates the patient's path.
Absolutely. These conditions might look alike on the surface, but the underlying causes, the mechanisms, are totally different. This study really helps us see that diagnostic dilemma playing out in everyday practice.
Okay, so let's set the stage a bit. AMD. We all know it as a major cause of irreversible vision loss, typically in people over 55.
Right. And the classic sign we look for is drusen, those yellowish deposits under the retina. Specifically, the Beckman classification says larger than 63 microns.
And we should probably mention reticular pseudodrusen, RPDs. They're also subretinal deposits.
Yes, and they're strongly linked to advanced AMD, definitely a risk factor, but they aren't considered diagnostic in the same way as those conventional sub-RPE drusen are.
Right. And genetic testing for AMD risk. It's emerging, but not quite routine clinical practice yet. Is it mainly due to cost and, well, availability?
Not routinely, no. So late-stage AMD, we're usually talking GA, the dry form, or neovascular AMD, the wet form. Anti-VEGF has been a game changer for wet AMD, but GA, that's different.
Explain GA a bit more. It's complex, right?
Very
Okay.
multifactorial. You've got oxidative stress, chronic inflammation. It all leads to this progressive loss of the photoreceptors, the RPE, that's the retinal pigment epithelium, and even the underlying choriocapillaris, the blood supply.
And what does it look like clinically?
On a color photo, you see that classic sharply defined scale area. You can almost see the choroidal vessels underneath. On OCT, you get that hypertransmission signal because the RPE is thinning or gone, and you see the loss of the photoreceptor layers above it.
And the big news recently, the new treatments.
Yes, the complement inhibitors. Pegcetacoplan, avacincaptad pegol. They don't reverse GA, but they have been shown to slow down the growth of the atrophic lesions, which is a significant step forward.
Okay, so that's GA. But then we have the mimics the inherited retinal diseases, IRDs.
Right. And this is where it gets tricky. IRDs are a really diverse group. Usually caused by a single gene defect, they follow Mendelian inheritance patterns, affecting the photoreceptors or the RPE.
How diverse are we talking?
Well, there are over 350 known causative genes, and about 30% of IRDs are macular dystrophies, meaning they primarily affect the macula, just like AMD.
And this is the Finocchi problem you mentioned.
Exactly. Some IRDs present with features, particularly chorioretinal atrophy, that look strikingly similar to GA secondary to AMD. It's a major diagnostic challenge.
Can you give some examples?
Sure. You might have EMP1-associated dominant drusen or certain CFH gene variants that mimic AMD. Conversely, conditions like Sorsby fundus dystrophy or late-onset retinal degeneration or EMAP extensive macular atrophy with pseudodrusen-like appearance can look like AMD with RPD.
It sounds like a diagnostic minefield.
It can be. And it's not just genetic conditions either. Some systemic disorders, like certain complement issues or abetalipoproteinemia, can also cause macular atrophy that looks like GA.
And why is distinguishing them so vital now?
Gene therapy. There are clinical trials underway for over 20 different types of IRD. Getting the right diagnosis means potentially connecting a patient with a life-changing gene-specific treatment.
But IRDs tend to present earlier, don't they?
Often, yes. But that distinction gets much harder in older patients. An IRD can certainly manifest or be diagnosed later in life, blurring the lines with typical AMD onset.
So even with our advanced imaging, OCT, FAF, near-infrared, it's still tough.
It is. These tools have vastly improved diagnosis, no doubt. But the end-stage appearance, the atrophy, can look similar even if the underlying disease process is completely different. We need nuanced interpretation.
Which brings us back to this study. Without routine genetic testing, clinicians need to be really alert to these mimics. So how did this Australian team approach it? What was their method?
Their main goal was to figure out the possible frequency of misdiagnosing GA in a typical busy clinical setting. They did a retrospective review, looking back at records from 1995 all the way to 2023.
That's a long time frame.
Nearly 30 years. It was at a large private multi-specialty practice in Melbourne Eye Surgery Associates. They pulled records from 14 different ophthalmologists, including medical retina specialists and other subspecialties.
So a good mix, reflecting real-world practice.
Exactly. They looked for adult patients diagnosed with AMD who had at least one OCT scan on file. Their initial keyword search across over 115,000 records flagged about 6,000 patients.
Then they had to narrow it down, presumably.
Right. They applied strict exclusion criteria, things like hydroxychloroquine use, high myopia over 6 diopters, previous retinal vein occlusions, basically anything else that could cause atrophy and confound the picture.
And the crucial step.
Identifying patients who had macular atrophy documented, but crucially without any evidence of conventional sub-RPE drusen at any point in their record.
Ah, so atrophy without the hallmark AMD sign.
Precisely. If a patient had both atrophy and typical drusen, they were assumed to have AMD and excluded from this specific review, focusing on potential misdiagnosis. Interestingly, they did not exclude patients based on having RPD, the reticular pseudodrusen.
Okay. How did they define atrophy in this initial screen?
They used standard criteria across imaging, hypertransmission on OCT with RPE and photoreceptor loss, well-defined hypoautofluorescence on FAF if available, and that classic RPE dropout on color photos. No AI or lesion measurements at this stage, just clinical assessment.
Who did this initial screening? It sounds like a huge task.
It was done by a single dedicated medical student who was thoroughly trained and supervised by a senior ophthalmologist. They even checked reliability, comparing the student's assessment to an expert's on 100 random cases.
And how did that go?
Pretty well, actually. Moderate agreement for identifying drusen, but strong agreement for identifying atrophy. Any complex or unclear cases were reviewed together. It suggests the process was robust.
So this process yielded a group of suspect cases.
Yes, 31 cases identified with atrophy, but no conventional drusen. These 31 then went for the expert review phase.
And this involved specialists.
2 senior retinal subspecialists, 1 expert in AMD, the other an expert in IRDs. They reviewed each case independently.
What information did they have?
Initially, only the multimodal images, OCT, FAF, color photos, NIR. They made a diagnosis based purely on the imaging findings. Then, only after that initial assessment were they given the patient's age to refine their final diagnosis. Still no AI used.
Do they have specific guidelines?
Yes, they were looking to classify cases as AMD with RPD, IRD perhaps suggested by features like hyperautofluorescent flex or a specific pattern, or just non-specific atrophy if a clear cause couldn't be determined.
What happened if the 2 experts disagreed?
Which happened quite often, as we'll see. If they couldn't reach a consensus, the case went to a 3rd senior medical retinal specialist who acted as the final arbitrator.
And ethics.
Right.
Data handling.
All standard protocols followed. De-identified data, secure management via REDCap, ethics approval obtained, and consents from everyone involved.
Okay, so the methodology seems solid, designed to tackle this specific question in a real-world context. What did they actually find? What was the misdiagnosis rate?
Well, remember those 31 cases flagged out of the initial 1136 with atrophy? That represents an initial potential misdiagnosis rate of about 2.8%. These were the cases with atrophy, but no classic drusen.
And was there a difference between specialists and non-specialists finding these tricky cases?
Interestingly, no significant difference at that stage. Retinal specialists flagged about 3.4% of their atrophy cases, while general or non-retinal specialists flagged about 4.2%. It suggests the difficulty isn't confined to one group.
Okay, then the 2 experts reviewed those 31 cases. Did they agree often?
They reached a consensus in only 52% of the cases. That's 16 out of 31. The average age for those patients was quite high, around 81 or 82.
And what diagnoses do they agree on?
It was a mix. 7 cases were agreed upon as AMD with RPD, 5 were agreed upon as IRD, and 4 were deemed nonspecific atrophy.
So almost half the time the experts didn't agree initially.
Exactly. In 48% of cases, 15 out of 31, there was no consensus. These cases then went to the arbitrator. The average age here was slightly lower, around 80.
And what were the final arbitrated diagnoses for those disagreements?
Again, a mix. 6 were classified as pattern macular dystrophy, 4 as nonspecific atrophy, 3 as myopic macular atrophy, and 2 as AMD with RPD.
This really highlights the difficulty, even for experts looking closely at the images.
It absolutely does. It shows just how blurry the lines can be based on phenotype alone.
So after all that expert review, and importantly, deciding the cases ultimately classified as AMD with RPD were not misdiagnoses of GA, what was the final recalculated potential misdiagnosis rate?
That's the key number. They ended up with 22 patients out of the original 1136 who had atrophy but were not deemed to have typical AMD or AMD with RPD. This translates to a potential misdiagnosis rate of 1.9%.
1.9%. That feels maybe lower than some might expect, but still significant.
It is relatively low compared to some other diagnostic challenges in medicine, yes. But breaking it down is revealing.
How did that 1.9% break down?
The largest group, almost 1%, 0.97% or 11 patients, were potentially missed IRDs or pattern dystrophies. Then about 90.7%, 8 patients, were nonspecific atrophy. And 0.26%, 3 patients, were actually myopic macular atrophy misclassified initially.
So the biggest chunk of potential misdiagnoses were likely inherited conditions.
That's what the data suggests. Now, what helped the experts make these calls, especially in the tricky cases?
Yeah, what features were most useful?
Patient history and significantly age were critical. Being younger, particularly under 70, was a major flag. They mentioned a 45-year-old whose atrophy looked like AMD, but both experts agreed it had to be an IRD given the age.
So age is a big clue.
It's a very important clue. 3 out of the 6 flagged cases under 70 ended up with a consensus IRD diagnosis. But crucially, it's not definitive. They had a confirmed IRD case in a 93-year-old, so you can't rule it out based on older age alone.
What about the appearance? Symmetry.
Symmetry often pointed towards a dystrophy. Highly symmetrical changes in both eyes tended to suggest an inherited pattern rather than AMD, which can be quite asymmetric. Although paradoxically, sometimes a clear lack of symmetry also ended up being diagnosed as pattern dystrophy in one case example. So it's complex.
Not a simple rule then.
No. And this brings us to imaging, which was hugely important.
Which modalities were most helpful? OCT.
OCT was vital for the initial screen, definitely for identifying and characterizing drusen or their absence. But for figuring out the cause of the atrophy once drusen were ruled out, fundus autofluorescence FAF was incredibly valuable.
How valuable?
Very, get this. In the cases where FAF imaging was available, the experts reached a consensus 78% of the time.
Wow, compared to
only 41% consensus when FAF wasn't available.
That's a huge difference.
Yeah.
It really underscores the power of FAF in these ambiguous atrophy cases. It gives you a clearer picture, doesn't it?
It really does. It helps assess the health of the RPE in a different way and can reveal patterns suggestive of specific dystrophies.
Okay, so pulling this all together. A potential misdiagnosis rate of 1.9%, mostly involving missed IRDs or pattern dystrophies. What does this actually mean for clinicians, for you listening in your practice?
Well, that 1.9%, while relatively low, isn't zero. It confirms there's a real measurable challenge in relying purely on clinical appearance, on phenotype, especially when genetic testing isn't routine.
And the fact that the experts only agreed about half the time initially.
Right. That really drives home the point. Even for specialists looking carefully, these cases are tough. There's inherent diagnostic uncertainty, a real blurriness.
What are the downstream consequences for treatment?
They're significant. If roughly 1% of patients thought to have GA actually have an IRD, they might be getting those new complement inhibitor therapies.
Which likely won't work for them.
Unlikely, yes. Complement dysfunction isn't considered the primary driver in most IRDs, so they're getting a potentially costly treatment with side effects that probably offers no benefit for their underlying condition.
And the flip side?
They're missing out. Missing out on the chance to be correctly diagnosed, potentially access gene-specific therapies if one exists for their specific IRD, or at least enroll in relevant clinical trials.
Genetic testing is the key there, But as we said, it's not always accessible.
Exactly. Cost, availability, interpretation. There are barriers. It's like knowing the right therapy might exist, but you can't confirm if the patient is eligible without that genetic key.
So what are the practical takeaways? What should clinicians do differently based on this audit?
Okay, key points. First, just general awareness. Be mindful that AMD copies exist, that other things can cause atrophy that looks like GA. Don't forget the RPD-only AMD phenotype. Those patients were in the complement therapy trials, so diagnosing them with AMD and considering treatment is appropriate based on current evidence. This study separated them out for the misdiagnosis calculation, but clinically they are considered AMD.
Good point. What else?
Guard against confirmation bias. This is huge. If you initially thought it was AMD, but then you get an FAF back that looks unusual, or the family history raises a flag, be willing to reconsider. Don't just stick to your first impression.
And consider other causes, like myopia.
Yes. Myopic macular atrophy can mimic GA, even in eyes without super high myopia. And again, those patients likely won't benefit from GA-specific treatments.
So when faced with an atypical case of atrophy, what specifically should trigger a rethink?
The study suggests focusing on age of onset, especially younger, family history of vision loss, smoking status, less common in IRDs usually, symmetry of the findings, whether the atrophy extends nasal to the optic disc, more typical of some dystrophies, and really making sure you're distinguishing drusen from other deposits like flecks.
And imaging.
Lean heavily on multimodal imaging, especially FAF, as we saw. If you have atrophy without clear drusen, FAF is probably your most helpful next step after OCT.
And if things are still unclear,
consider targeted genetic testing. If the clinical picture and imaging are ambiguous, that's where genetic testing can provide diagnostic certainty and guide management appropriately.
Makes sense. Now, we should also quickly touch on the study's own assessment of its strengths and weaknesses.
Definitely. Strengths. Large, real-world data set, nearly 30 years, multiple clinicians involved, that gives it good external validity. And the long follow-up helped confirm the presence or absence of drusen over time in many cases.
Limitations.
There are a few important ones. The initial screening by a medical student, though supervised, the keyword search might have missed some cases. They focused only on excluding typical drusen, so they might have underestimated misdiagnoses in IRDs that do present with drusen-like deposits.
And the data itself, over 30 years.
Yeah, variable imaging quality and availability. Only 15% had FAF, which we now know is super helpful. The final number of 31 cases reviewed by experts is relatively small for deep statistical dives. And critically, no genetic confirmation, so all the final diagnoses are possible or putative, not genetically proven.
Right, important context. So let's wrap this up, the main message from this Australian deep dive.
I think it's that while the overall rate of misdiagnosing GA secondary to AMD might be relatively low, around that 1.9% mark, the potential impact on individual patients is high. We absolutely need to remain eye-aware of the mimics, the dystrophies, the other atrophic conditions.
Because getting the diagnosis right isn't just academic.
Not at all. It's about ensuring patients get the right pathway, whether that's complement therapy for GA or genetic counseling and potential gene therapy trials for an IRD.
And it really seems to underscore that for IRDs, genetic confirmation is often the gold standard for a truly confident diagnosis.
It does. So maybe a final thought for everyone listening. When you see that challenging case of macular atrophy, how far are you willing or able to go to get that clear diagnostic vision for your patient? Especially now, with targeted therapies becoming a reality.
What steps can you take tomorrow in your clinic to integrate some of these lessons? Using FAF more, asking more detailed family history, considering genetics sooner in ambiguous cases.
Food for thought, definitely.
Absolutely. And for those of you who really want to get into the nitty-gritty, you can find a link to the full study right there in the podcast description.
It's worth a read if this area interests you.
And hey, if you found this deep dive helpful, if these insights were useful for your practice, we'd really appreciate it if you could take a moment to follow the podcast.
And maybe even leave us a 5-star rating. It genuinely helps us keep bringing these kinds of clinical discussions to you.
So thank you for joining us today.
Thanks, everyone. Keep exploring, keep learning.
And keep asking those crucial questions.